Hi everyone, so we're going to talk about the key points of Chapter 2, starting with developmental disorders. So at any point in the prenatal development period, or during the birth process, which is the perinatal period, or lastly during the neonatal and postnatal periods, development may diverge from normal, and that's going to generate a developmental dilemma. So some of these dilemmas include congenital anomalies. So these are some possible causes of congenital anomalies that you need to know about. Congenital anomalies can either be genetic or non-genetic. Sometimes they're both, though. They're typically present at birth, but they might not be detected until later in infancy or childhood. Some non-genetic causes can include infection in the mother. There's a big deal going around right now with this whole Zika virus thing. And Zika virus, if contracted by a pregnant woman, typically causes anencephaly. And we're going to talk about that in a little while. But that would be an example of an infection contracted by the mother. Could also be a result of drugs taken by the mother, the age of the mother, that plays into, that factors in quite a bit when you're looking at things like Down syndrome, spina bifida, and some of the other neural tube defects. Radiographic examination made in early pregnancy, or injury to the pregnant woman or the fetus. So genetic disorders and syndromes are a form of congenital anomalies, and it's a result of an abnormal gene taking up residence on one of the 22 pairs of non-sex chromosomes. So a couple of things I want you to note here, that when one gene is on autosomes, or when the gene is on an autosome, it's called an autosomal inherited condition. So if the extra gene that is not supposed to be there is living on an autosome, then it will be an autosomal inherited condition. This can result from both dominant or recessive traits. The parent who carries the abnormal gene has a 50% chance of transmitting the defective gene to each of his or her offspring. So that's half. And so even though one child may get it, the next child may not. You could end up having all of your children with the same genetic anomaly. When the condition is considered an autosomal recessive inheritance, the parent's abnormal genetic makeup must have genetic errors on both of the genes of the pair, resulting in the carrier usually having no symptoms of the disorder. So just kind of be mindful of that as well. Prematurity. The condition of prematurity describes the birth of a low-weight, underdeveloped, and short gestation infant. So the babies weren't in long enough. Because they weren't in long enough and they were born too early, they didn't have enough time to fully form all of their functioning organ systems and immune system and all of that business. These infants are at a greater risk than full-term infants for developing serious health problems, including cerebral palsy, mental retardation, chronic lung disease, GI problems, vision and hearing loss, and also multi-system developmental delays. Just a note here that I would like for you to be aware of: prematurity is actually the leading cause of death in the neonatal period. Okay, so let's look at some of the developmental disorders that are related to prematurity. One we have here, Down syndrome. Down syndrome is a genetic syndrome where the individual has 47 chromosomes instead of the usual 46, and that results in a congenital form of mild to severe mental retardation that is accompanied by characteristic facial features and distinctive physical abnormalities. Down syndrome is not entirely, I think I might have actually put this in the wrong spot. Down syndrome is not entirely related to prematurity, but it has been found to be more common in children born premature. Or I guess that should go backwards. So babies who have been discovered to have Down syndrome in utero typically are born premature, and that causes a whole host of additional complications for them on top of the Down syndrome. So the next one is IRDS, which is Infant Respiratory Distress Syndrome. And this is where the neonate exhibits signs of respiratory distress, including nasal flaring, grunting respirations, and sternal retraction. So you can see their chest expand and retract very, very visibly. And the infant becomes cyanotic, so they start to turn blue. IRDS, or hyaline membrane disease, as it's sometimes known as, is similar to adult respiratory distress syndrome in that the patient suffers acute hypoxemia caused by infiltrates within the alveoli. So in the very itty bitty teeny tiny parts of their lungs, they've got some problems there. The alveoli is where the gas exchange takes place between carbon dioxide and oxygen. And so if there's some problems in there, then they can't properly make this exchange. And so then the baby becomes hypoxic or has too little oxygen in their blood. The NICU staff will observe the infant for signs of respiratory distress, and immediate intervention is going to be instituted at the first signs of distress. We don't mess around with babies not breathing very well or turning blue. We make sure that they are watched very carefully after birth, and that at any signs of respiratory distress, the babies are receiving appropriate medical attention. The first indications of ERDS are increased respiratory efforts of the newborn and a history of prematurity. Let's look at laryngomalacia, tracheomalacia, and bronchomalacia. So these are all forms of obstructive airway conditions. They can evolve as separate conditions, or they could be a combination with one or more of them being seen together. So the primary cause is softened or underdeveloped cartilage, which allows the airway structure to collapse. Next, we have necrotizing enterocolitis. That's abbreviated commonly as NEC. You'll see it that way more than you will see it as necrotizing enterocolitis. It's thought to be a breakdown in the normal defense system of the GI tract, which allows the normal flora of the GI tract to invade the intestinal mucosa. NEC is an acute inflammatory process caused by ischemic necrosis of the mucosal lining of the small intestine, large intestine, or both. So basically, the infant's going to be hospitalized, usually in NICU, because what is happening is their GI tract is dying. That's what necrotizing means. So next we have pediatric nervous disorders. There is spina bifida, and that is where the posterior portion of the bony canal containing the spinal cord is completely or partially absent. This is usually due to a failure of the posterior spinal processes to close. There are three types that you should be aware of. Make sure you read about these in your textbook or in the lecture notes. There is spina bifida occulta, a meningocele, and a myelomeningocele. So basically what happens is, I don't know if you guys have ever seen the movie Shallow Hal, but in Shallow Hal, the one guy, the short, bald guy, has a tail, and that is open spina bifida. So it's basically where the tailbone is on the outside of the body instead of on the inside of the body. Cerebral palsy can be congenital or acquired. Cerebral palsy is a condition consisting of a group of disorders possibly involving the brain and nervous system functions that deal with movement, learning, hearing, sight, and thinking. Spastic cerebral palsy is characterized by hyperactive reflexes or rapid muscle contractions. And a lot of times these kids will look like they have jerks, uncontrollable jerks or tics. Aphetoid CP is characterized by involuntary muscle movements, especially during times of stress and reduced muscle tone. And then a patient may exhibit all three types in varying degrees from mild to severe. So be aware of that. They may have all three types of CP symptoms in one degree or another, or at one level or another during different life situations or another. Ataxic CP is characterized by lack of control over voluntary movements. They have poor balance and they have a wide gait, so they walk with their legs spread very far apart to try to help keep them upright. Most times cerebral palsy is suspected during routine well baby or well child visits. Okay, so muscular dystrophy is a progressive degeneration and weakening of the skeletal muscles where muscle fibers are abnormally vulnerable to injury. MD is the cause for hemophilia and color blindness. The disease does affect only males, and it's generally inherited through the female carrier. So if a boy has MD, he got it from his mother's genetics. The affected muscles sometimes look larger than normal because fat replaces atrophied muscle. The child may also have lordosis or other spinal deformities, so they could have some abnormal curvatures in there. Most common and best known type of muscular dystrophy is Duchenne's. The prognosis for a child with Duchenne's muscular dystrophy is very poor. The child is usually confined to a wheelchair by the age of 9 to 12 years, and they have very limited function of their extremities. Okay, and lastly in this category, we'll talk about anencephaly, and I mentioned this a few moments ago when talking about the Zika virus. Anencephalic fetuses or neonates has no cranial vault and little cerebral tissue. This is the most severe form of a neural tube defect. It occurs early in gestation with failure of the cephalic aspect of the neural tube to close. So what happens is the baby doesn't develop a brain or a cranium, or if they do, it doesn't form fully on the back of the head. There is something called microcephalic fetus, and that fetus or neonate has a very small amount of cerebral tissue and may survive a few days or a few hours or days. So there's two. There's anencephalic, and med-term means without, and so that is without cerebral tissue, and micro means small in medical term, and so micro means that they have very small amounts of cerebral tissue. These fetuses or neonates lack sufficient cerebral tissue to sustain life, so these babies unfortunately do not live very long. All right, so pediatric cardio diseases, we have cyanotic defects, and the infant with cyanotic defects appears to have a blue tinge to the lips and tongue and nail beds. Central cyanosis is a sign that the atrial blood is not fully oxygenated. The 5 main cardiac causes of central cyanosis are Tetralogy of Fallot, which we're going to talk about in just a minute, transposition of the great arteries, which means that the pulmonary artery and the aorta are backwards, truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous return. You need to make sure you read about those in your textbook, and you'll find more information there on those other conditions. PDA is a patent ductus arteriosus, and this results when the ductus fails to functionally close. So basically what happens is when the baby takes its first breath after birth, it closes off a bunch of valves that were open to allow for circulation during being in utero. Excuse me, I lost my train of thought there for a second. And so because the baby was breathing fluid in the womb and they are breathing air on the outside, some things have to happen. And so they have these physiological changes where some of these ducts shut off, and that allows the baby to breathe air in through their lungs. So with PDA babies, one of the ducts doesn't close right, and then they have some issues with blood shunting back and forth to places it shouldn't be. So during normal fetal circulation, the patent ductus short circuits, shunting the circulation from the lungs, and instead directs blood from the pulmonary trunk to the aorta, instead of from the pulmonary trunk back into the atrium. The PDA is detected during a physical examination when a classic machinery murmur is heard on auscultation, and palpitation will reveal a thrill. The prognosis for these infants depends on the presence of other anomalies. Sometimes they will treat this with diet. Other times they will do, they do a surgical intervention to close up that duct. So it just kind of depends on the severity for the babies, but overall prognosis isn't too terrible for them. Tetralogy of Fallot is a combination of 4 congenital heart defects, including VSD, pulmonary stenosis, dextroposition of the aorta, and right ventricular hypertrophy. Most cases are discovered during the newborn exam, and this is where deoxygenated blood enters the aorta, causing the symptoms of hypoxia, tachycardia, tachypnea, dyspnea, and seizures. None of those are good for a newborn. So tetralogy of Fallot is a pretty serious event and requires immediate treatment. Okay, musculoskeletal malformations. We have clubfoot. That's where the heel is drawn up with the lateral side of the foot being convex and the medial aspect being concave. A lot of times as kids are clubfoot, they look pigeon-toed. Clubfoot is an obvious non-traumatic deformity of the foot of the newborn in which the anterior half of the foot is adducted and inverted. So again, they look pigeon-toed. True clubfoot cannot be manipulated back to the proper position, whereas distortions that are caused by intrauterine position usually can't be. So sometimes when babies are born, they've been curled all up in their mama's belly in a weird way, and their feet will appear like they may have clubfoot. But usually, if that's the case and it's just a weird position, you can straighten the baby's foot back up. With true clubfoot, you can't do that. DDH is developmental dysplasia of the hip. That's previously known as congenital hip dysplasia or CHD, so you might still see that both ways. It's an abnormal development of the hip joint that ranges from an unstable joint to dislocation of the femoral head from the acetabulum. And so basically that means that the ball on the top of your hip bone pops out from the socket. This dysplasia is apparent during newborn exam, and the exact cause is unknown. Okay, and then the last one here, cleft lip and palate. There's a hole in the roof of the mouth. The cleft may extend completely through the hard and soft palates and into the nasal area. A cleft lip or a hair lip is congenital birth defect, which consists of one or more clefts in the upper lip. So I'm sure you guys have seen the pictures of cleft palate babies. They do require surgical intervention to repair that cleft lip or that cleft palate. Okay, so genitourinary conditions. We'll start with Wilms tumors. They are nephroblastomas, and it's a highly malignant, so very cancerous neoplasm of the kidney that affects children younger than 10 years. Some symptoms patients may experience as a result of tumor are hematuria, so blood in their urine, pain in the abdomen or chest, hypertension, which is elevated blood pressure, anemia or low iron in the blood, vomiting, intestinal obstruction, constipation, weight loss, and fever. Wilms tumors are the fourth most common childhood cancer. Cryptorchidism is the failure of the testicles to descend from the abdominal cavity into the scrotum, and it's typically detected at birth or shortly thereafter. This condition is palpable, which means you can feel that the testicles are not in the scrotum where they're supposed to be, and it's observed during the newborn examination. The diagnosis is by visual inspection and palpation, starting above the inguinal ring and pushing downward on the inguinal canal toward the scrotum. Treatment is important because untreated cryptorchidism may lead to sterility in the adult male. So if he has a testicle that hasn't dropped, if a little boy has a testicle that hasn't dropped, you want to get that treated. Otherwise, they run a pretty healthy risk of not being able to father children later on. There's also an increased risk of testicular cancer and untreated cryptorchidism, and there unfortunately is no accepted form of prevention for this. So it's just kind of one of those weird things that happens to some kids, and if it does, then it just needs to be fixed. Phimosis is the stenosis or the narrowing of the opening of the foreskin in the male that leads to an inability to retract their foreskin. So basically, for uncircumcised males, their foreskin slides up over the head of their fetus or their glans penis, and with phimosis cases, that foreskin is no longer movable. It becomes like rigid and difficult to slide back down so that they can clean underneath the glands or whatever they need to do. The symptoms may develop later in uncircumcised male, even into adulthood. It can be problematic if it's acquired after the neonatal period, and that's because urine and other things fall back down in there under that foreskin, and if they can't retract it to clean, then that causes a host of infections and problems for them. The child may have difficulty with urination, or the parents may have difficulty with cleaning the area under the prepuce of the glans penis, which is the area underneath the head of the penis. The cause for phimosis is unknown. The only definitive treatment to cure it entirely is circumcision. So if parents have not had their child circumcised due to a religious reason, then phimosis may be something that they are just going to have to deal with if it becomes a problem for them. The only time that that they may want to, that you may be able to persuade them to reconsider, is if the child is having trouble urinating, because obviously you need to do that. So more conditions here. It's GI conditions. You have pyloric stenosis. It's a congenital disorder. Is a gastric obstruction associated with narrowing of the pyloric sphincter at the exit of the stomach. Treatment consists of surgical intervention in which the constricted pylorus is incised, which is called a pyloromyotomy, and it's sutured to relieve the obstruction. So basically, if you look at the pictures in your textbook, you can kind of see where the pyloric sphincter is. It is strictured, and it becomes, all bound up and twisted up and closed off, and so they just go in and snip it and open it back up. The prognosis is good with prompt surgical intervention. Hirschsprung disease is a congenital condition. It's an impairment of intestinal motility that causes obstruction of the distal colon. So things don't move through the guts the way that they're supposed to, and then things get caught up at the end, at the distal colon, so they get backed up. Some signs and symptoms differ slightly depending on the age of the child experiencing an exacerbation of the condition. So statistics indicate that males are more likely than females to have a megacolon, which is an enlarged colon or a very large colon, and that the risk is increased in children with Down syndrome. Hirschsprung disease is actually believed to be a familial congenital disease. Then last up, we have cystic fibrosis, and cystic fibrosis is an autosomal recessive inherited disorder. It's a chronic dysfunction of a gene called the cystic fibrosis transmembrane conductance regulator, which is CFTR for short. That affects multiple body systems. So normal growth and ability to thrive are reduced in kids with cystic fibrosis. They develop thick, sticky mucus that accumulates and obstructs the glandular ducts. So it obstructs all of their stuff. They have this thick mucus, and they cannot clear it out in a sufficient manner to allow them to breathe normally or some of their body parts to function normally. The clinical effects of CF are dry paroxysmal cough, exercise intolerance, pneumonia, bulky diarrhea, vomiting, and bowel obstruction. Pancreatic changes replace normal tissue with fat and fiber, and then sweat glands increase the concentration of salt. So here's the thing with cystic fibrosis. They are highly susceptible to secondary infections. And one of the cardinal rules for treating people with cystic fibrosis is to never place them within close distance, like in the same room, in the same house, with somebody else who has cystic fibrosis, because they can pass back and forth infections and actually shorten one another's lifespan. So, respiratory system and GI tract, fetal conditions, other things here for you. You have asthma. I'm sure everybody at some point has heard of asthma in their life. It's chronic, reversible obstructive disease caused by increased reactivity of the tracheobronchial tree to various stimuli. So you have labor breathing. Asthmatic patients present an alarming situation if their asthma control is uncontrolled. The bronchial spasms of asthma can be triggered by many extrinsic or allergic or intrinsic, which are non-allergic factors, including stress, heavy exercise, infection, inhalation of allergens, or other substances. The best tool available to reveal the degree of airway obstruction is a test that we call a PFT, or a pulmonary function test, and that will tell us what the lung capacity is in several measurements for that child, and then allow the physician to appropriately place them on medication to assist with controlling their asthma. Leukemia is a cancer of blood-forming tissues. It's the most common childhood malignancy. Make sure you remember that. It's characterized by an abnormal increase in the number of immature white blood cells, or undifferentiated blastocytes. There are two general types of leukemia that are found in children. One of them is ALL, which is acute lymphoid leukemia, and the second is acute myelogenous leukemia, which is AML. And lastly here, neuroblastoma is a cancer of the sympathetic nervous system. It's the third most common childhood malignancy. Neuroblastoma can arise from any site in the sympathetic nervous system. The symptoms include abdominal masses, abdominal pain, fullness, anemia, bone pain, fever, hypertension, and weight loss. Okay, so those are just a few of the diseases. There are many, many more diseases and conditions covered in Chapter 2. Again, you are responsible for reading all of that material and knowing everything, because everything in the textbook and throughout the lecture notes, and the extra reading that I may post with the lecture notes, all of that is fair game for exam questions, so just be aware of that. But these are the things that are more commonly noted in childhood diseases, and hopefully you have a little bit better understanding now. We'll talk to you in Chapter 3.